I am Evan Argentar, and I will be presenting arthroscopic rotator cuff repair with bicep augmentation. There are many advantages of using the bicep tendon as an augment for rotator cuff repair, especially in situations with large tears that have high rates of failure. Most importantly, it's free and does not have the extra costs associated with other allografts, and this can be used in situations where cost reduction is important, like surgery centers. Additionally, in countries or in situations where cadaveric options are not available or undesired, this is a nice alternative. Unlike other tendon transfers, there is no additional surgical incisions that need to be created, as the bicep tendon is in the zone of surgery. In situations where tuberoplasty is desirable, the bicep tendon can be harvested such that it can be extended laterally to serve as a tuberoplasty option. Lastly, it is still possible to do concurrent bicep tenodesis. This surgery can be done both supine and then the lateral beach chair. My preference is lateral beach chair, and this is the arm lateral. Here's a picture of my suture passer in preparation for placing it through Navisor's portal. Diagnostic arthroscopy should be performed first. I generally use this technique for large to massive rotator cuff tears, but the diagnostic arthroscopy should all confirm that the bicep tendon not only is present but has good quality. From a lateral portal, using luggage handle technique, a fiber link suture can be placed through the bicep tendon at the level of the cartilage greater tuberosity junction. Once this is performed, it should be extracted using the suture passer through the Navisor portal previously shown. By pulling traction from a lateral to medial position, you can then pull more of the bicep tendon into the joint. In the subacromial space here, you can see that additional bicep can be visualized by doing some reverse biting debridement of the bicep tendon sheath. Once the bicep tendon has been optimally exposed and pulled into the joint by means of pulling traction on the suture now coming out of the Navisor portal, a second luggage handle style suture is placed into the more distal aspect of the visualized bicep tendon. Once both luggage handle ties are in the proximal and distal aspect of the visualized bicep tendon, tenotomy can be performed in between. Once tenotomy is complete, using standard technique, a bicep tenodesis can be performed with the more distal bicep limb. My choice is a 2.4 millimeter Arthrex push lock. After bicep tenodesis is performed, the suture coming through Navisor portal is extracted laterally. Using standard technique, the bicep tendon is manipulated such that it sits more superior at the 12 o'clock position on the greater tuberosity. Once this more central superior position is obtained, it is tensioned and placed in a lateral swivel lock. If there is sufficient intra-articular bicep tendon that had been harvested, it can easily be used to concurrently serve as a tuberoplasty on the greater tuberosity. I then routinely place a more medial anchor to better secure the more medial aspect of the augment bicep tendon by means of a 2.6 millimeter knotless fiber tech. Standard tensioning after deployment of this anchor clearly shows that the bicep augment is compressed on the more superior aspect of the greater tuberosity. The bicep augment is now complete. I generally do a transosseous equivalent rotator cuff repair. Anterior medial, on the medial row, 2 swivel locks are placed, and using standard technique, compression is obtained by playing 2 lateral anchors in the greater tuberosity. Rehabilitation follows standard rehabilitation for massive rotator cuff tears. In my practice, I keep them in a sling for 6 weeks and then begin physical therapy working on range of motion with strengthening occurring at 3 months. In conclusion, using the bicep tendon as an augment for massive rotator cuff repair is easy, cheap, and accessible, and I believe that this likely will improve clinical outcomes. More research is needed, of course, both clinical and biomechanic, to evaluate the utility of this augment.